Welcome everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have today we have Dr. Ananda Kisor from Kolkata, and he is teaching us about orthopedic, uh, the newer question which is asking in the exam OSCE method. So, what are the changes and what are the new variety of question can be possible? So, it's none other than Pal sir who can
Ah,
explain it better.
ah.
So over to you, sir.
Thank you, Janki. So thank you, Dr. John Mukhopadhaya also. So for his this continuous effort to provide the knowledge for the orthopedics. Now, without wastage of time, I just want to highlight the newer trend of OSCE. Now, all of you know the OSCE is going to be the main part of the examination in our DNB examination, and also it is coming in a big way in MS Ortho also. Now, the DNB examination, it is a separately you have to pass in this uh, for this OSCE. Now, for that, there are some trends are being changed. Now, what are the newer trends? Newer trends are basically there are different videos. Videos are being used, and there are have to take the clues of the videos. So, without wastage of time, just I want to start. A 22 years old man. So this is this sort of structured problem is given, and you have to take the hint from that problem, and we have to observe the video, and from the video we have to take the clue for the answering the questions. Now the problem is there's a 22 years old man complaining of pain in his left groin following walking after half an hour for last 6 months, with gradual reduction of the walking distance over the last 10 years, with history of limping since infancy following fever. So see, there are several hints. Following fever, infancy, there is some problem which is started the limping. So it most probably it is a some infective process. And see, check up the videos, what is going on. Now check. This is the points. How to make the hints. How to take the clue. Watch the motions of the head, shoulder, trunk, hip, knee, and ankle and foot. See, the head is moving. Head is moving side to side. This trunk is also moving. See, so that the knees are normally is flexing, and see there is no abnormal mobility of the foot and ankle. But there's basically the head is moving, the shoulder is moving. Now, if you watch very carefully the shoulder is moving not only in the coronal plane, but also in the sagittal plane also. See, there are some backward movement of the trunk. So basically, it is a one word is used. There is swaying of the trunk, as you can see here. So if you have to, so first question is identify the gait. So the abnormality is, see, the more head is moving, there is swaying of the head. There is like a pendulum of an old clock. It is moving the head in the coronal plane. The shoulder is not only moving in the coronal plane, but also in this sagittal plane. So it is instability in the both the plane. So basically, and you see the shoulder also, it is drooping. It is drooping down. Shoulder is also, it is drooping down, and see the trunk is deviated on the left side. See the abnormal distance between the hand and the trunk. So that is basically, it is a short limb component. There is instability component both in both the planes, sagittal as well as the coronal. So it is unstable gait and the short limb gait, unstable in both the planes. So what is the probable diagnosis? See, there is an infancy fever following limping. So most probably there is some infective process which is most common in the hip. So it may be a case of unstable hip following the pathological dislocation or pathological destruction of the proximal femur in the infancy. Okay, so it is a sequelae of septic arthritis. Now, what are the differential diagnosis, as it is starting from very early infancy? So the next diagnosis would be definitely, it will be a high riding. This is a neglected, there is developmental dysplasia of the hip. Now, suggest the investigation for confirming the diagnosis is simple. That is the radiograph. Mention the principles of the management. Now will come. See, so this is a bipedal unassisted short limb gait. It's a biplanar unstable component. of a on the left side. So this is a, see, there are two word was used. One is a drooping or dipping down of the shoulder, and also the swaying of the body, not only in the sagittal, also in the coronal plane, both the condition. So this unstable and short limb gait. Now the differential, so diagnosis is most probably it is a hip instability from either proximal femoral defect or the septic arthritis. The history, there is history suggestive of the fever, so it's most probably it is a septic arthritis. Most probably it is a Hanga classification. So they all, if you know the five types, this is the 4 and 5 is the instability. So it is a most probably it is a Hanga 4 and 5, and or there is a very high riding hip in DDH. Now this is the radiograph, as you can see here. See, this is a definitely it is a post septic arthritis. Now the basically the what are the investigation? Investigation basically is a plain radiograph of the pelvis, including both the hip, IP, and lateral. Now what are the principles of the management? Principles of the management, there are the two way. Either it's a salvage or the sacrifice. Salvage, it is a elixir of heat reconstruction, or the sacrifice. This is the theoretical. I'm touching on this. How clinically you differentiate, that may come in the questions. How clinically you differentiate between the post-infective instability from the DDH. So that is a Dahanka type 4-5 or the DDH. So there is abnormal excessive hip motions in at least in one direction. Okay, so that would be the in favor of the post-infective instability, whereas in the DDH, there is the head is relatively present. There will be abduction, restriction of the abduction and the internal rotation, but there will be no excessive motions. Now, what is the plan? That is, there is Ilizaro hip reconstruction. That basically it is consisting of the double osteotomy plus limb length discrepancy correction, or there's a THR. I'm not going to detail. These are the theoretical component. What are the radiographs are used? The standing orthoröntgenogram, pelvis is affected hip like this. Proximal, there are two osteotomy, proximal osteotomy and the distal osteotomy. So there are different. You can read from the internet or the book. Teacher, there are several issues that I'm not going into detail, so that it is a theoretical component. Now, what is the valgus correction? How much valgus correction? How do you calculate? So this is the radiograph of fully adducted position of the affected limb. So in this case, the first line is drawn along the highest point of the left wrist, and another line is drawn at the 90-degree from this. And how much adduction is possible? Suppose it is a 40 degrees, so we have to add 40 plus and overcorrection 15 degree. Suppose it is a 30 degree, 30 plus 15 is equal to 45. As it is 40 degree, it is adducted. So it is a 40 plus 15. So this is a 55 degree abduction is required. So valgus is required. So accordingly, you have to correct the mechanical alignment, and so by the distal osteotomy. At the same time, in the distal osteotomy component, you can the lengthen the limb, so that limb length discrepancy will be corrected. Now see, this is the another this the video you can check. So I have the questions are identify the test steps, which one is the correct, A or B. Check this very carefully. Both are moving simultaneously. Say the patient is being lateral, the opposite limb, which is lower one, which is flexed at the hip and knee. Now hip of the affected side, in one side it is not done anyway. On the left side it is done abducted. Check again. So here it is. Here, see the B, what is done? See, the hip is abducted and extended, keeping the knee flexed. Now it is allowed to drop to the floor, to the bed. Now it is not dropping, but it is little bit lower, but it's not dropping. So what is the problem? So basically, which one is the correct, A or B? So basically, which test? It is the Ober's test, and the A is incorrect, as the hip is flexed and internally rotated. As again you can check here, it is nothing, it is done, or the affected limb, it is hip is flexed and internally, so it is a incorrect one. Whereas the B, this the exact step is we have to flex the opposite limb to obliterate the lumbar lordosis. Now the affected limb should be abducted and extended at keeping the knee flexed. This is the classical one, and gradually limb is allowed to drop to the floor. But if see, it is lower down, but it is not fall down. Okay, so how much lowering is normal? So it should be at least more than 10 degree. So this is the most, this is the parameters. So basically A is completely wrong method. B is the partial. It is the partially corrected because initially it is classic, then adding modification. So you can take it as a normal one. It is a so what are the steps? So patient should be in lateral position, opposite hip knee should be flexed to obliterate the lumbar lordosis. We have to stabilize the pelvis. Affected, that is the upper limb should be hip knee 90-90 flexed. Affected hip should be extended and abducted. So allowed to fall towards the bed. So this is very, very important. Avoid the flexion and the internal rotation of the hip. Why? Now coming in the subsequent. See the same video. It is given. So this is with a problem. So this is a 23 years old long distance runner complaining of pain in his outer aspect of the left knee for the last 2 months while running, showing the clinical test below. This clinical test reproduces the same pain which he experienced during the running. So see if I see what is the see it is this is the classical Ober's test. So this identify the test is Ober's test. See hip knee flexed, knee is flexed. Now it is now see it is not dropping down. So now it is positive. So this is the exact test. So in the other side, what is happening? There is a partially extended, flexed. So this is the classical and the true Ober test. Now, how do you interpret? So if there is a not dropping down, these are the effectively not dropping down more than 10 degree. So this it is positive. Now mention the probable diagnosis. So this is a basic C. So answer is basically Ober's test. So basically it is the iliotibial band or the hip capsular or the gluteus maximus contracture which don't allow the adduction of the hip. That is not more than 10 degree lowering from the horizontal line. Now if the itibial band is normal, the leg will adduct with the thigh dropping down slightly below the horizontal and the patient won't experience any pain. So in this case, test is negative. Now, if the iliotibial band is tight, the leg would remain in the abducted position. In this case, the test is positive. Now, this test is done for the lateral knee pain. There are several conditions. Where will you examine the Ober's test? So, there is the lateral knee pain, hip abduction contracture, postural abnormality, iliotibial band contracture, as well as the patellofemoral instability. So, if it is a permanent dislocation of the patella or the habitual dislocation of patella, we have to examine this Ober's test. Now, what are the associated findings? See, there are at least we have to check from above downwards. There are several associated findings, maybe associated with IT over stress positive conditions, maybe 9 or 10 in 10 deformities. See, we have to enumerate from the back downwards. So there is a secondary lumbar lordosis to compensate the flexion deformity as the iliotibial band is contracted. Iliotibial band is basically leads to flexion, abduction, external rotational deformity of the hip, and that flexion deformity is concealed by the secondary lumbar lordosis and the scoliosis. As you can see, this is secondary scoliosis, secondary to the hip contracture. And the primary problem is the iliotibial band contracture leading to flexion, abduction, external rotation deformity, and that can lead to, because of the prolonged flexion of the hip, that can lead to prolonged flexion of the knee, which can lead to triple deformity, triple or quadruple deformity of the knee. And again, if there is a flexion of the hip and knee, there's some apparent shortening of the limb, and that apparent shortening can be compensated by the secondary equinus deformity, secondary plantar flexion deformity. If it persists, that can lead to equinus deformity. See, there if we enumerate, there are several 9 to 11 associated deformity. In it may be associated with some iliotibial band contracture. Now, what are the other tests to confirm? So, whether it is a true iliotibial band problem or due to some other problem for the hip pathology or the, so for to test the whether it is a true due to iliotibial band problem. So basically, you have to test the Nobel's test or the Rennie's test, which is separate pain provocation test designed to identify the iliotibial band syndrome. Now, now we have to come to the exact topic, the iliotibial band syndrome, which is very common in young athletes. So that the patient may complain of the lateral knee pain in the athletes. Now the same test, see the same test can come in different way. So that is the newer trends of OSCE. As you can see here, identify the test, same the questions is the OBERS test, mention the anatomical explanation of the test. Anatomical explanation is basically iliotibial band. See, this is a faulty test. So as if there is abduction extension is not done. So basically it can be done in different way. So what is the anatomical explanation? As the iliotibial band receives the insertion of the gluteus maximus from the back and the tensor fascia lata, and the tensor fascia lata is running anterior and lateral to the hip joint. Basically, they act as a flexors and the external rotators of the hip joint. So it becomes taut whether it is abducted and extended, and the internal rotation, that is opposite, that is external rotation. So in this condition the iliotibial band becomes taut. So this is the anatomical explanation. Now mention the limitation of this test. So see, as there is significant contraction, so this the iliotibial band is contracted, that can lead to contraction of the rectus femoris. Rectus femoris also become stretched, and that can cause pain on the other side of the knee. So patient may complain of unpleasant sensation on the around the knee from the not only from the lateral but also from the medial aspect. Patient may be uncooperative. So that is the limitation. Now what is the modification? So see, this which one is now a same test may come in different way. Say this is the two videos are playing side by side. Which one is the classical over test and which one is the modified over test? Some modification. So who modified? This is the Kendall modified. Kendall is a famous book. You must read that book of Kendall. And so see, the left one is the classification. It is a modified. So it is the knee is extended. Initially, the knee is flexed. You can start with, you can, if a patient is complaining of discomfort, patient you can do with the knee extension. So you have to abduct and extend the hip, but you can modify it with the knee extended. So there is less pain on the medial and lateral aspect of the knee joint. So this is Ober's test. So everything is discussed. So if the patient complains of knee pain, stop the test and perform the modified Ober test. This is the Kendall's modification. Now some it is all like everything it is discussed. I'm not going to do now the another test. This is the test is Nobel's test, as you can see here. This is to identify whether it is truly the iliotibial band. It is the pathological. So we have to press it. We have to press both the sides, especially the iliotibial band, and gradually it will make a hip knee 90-90 flexed, and gradually to extend it, and it is short of 30-degree flexion to full extension. If the patient will complain of pain on the lateral side, this is the provocative test. This is the Nobel's compression test, as you can see here. Now this is the steps. We have to press the iliotibial band on the lateral side, flex the 99 hip knee 90-90 flexed, gradually extend. If the patient is complaining of pain at 30-degree flexion to knee extension, so it is positive. So it is a pain or maybe palpable snapping, rubbing, that is quickly hinge like crepitus. So everything will diagnose there is a iliotibial band syndrome. Now see, this is the video. Another video is a 23 years old athlete complains of lateral knee pain and the crepitus while running for last 3 months. So which test it is done? See, on the both the sides it is done. So lateral knee pain, again, it is basically, so that is almost, it is looking like the Nobel's compression test or the Rennes test, but it is a different test. It is known as the Rennes test. So Rennes test, what is this? It is a probative test of the iliotibial band syndrome, where the body weight is used during the knee flexion. And if the patient is complaining of pain on the lateral side, so that is due to iliotibial band friction syndrome, and it is characterized by pain on the lateral femoral condyle. Now see, this is another video. This is looking almost similar. Is almost similar. Patient is complaining of, see the apprehension, and see this is patient is standing on the right lower limb, gradually flex it, but patient is complaining of some instability. You can see here Now, what are the points to be checked? This again is a 23 years old athletes complaining of occasional pain after jumping. Not only there is no complaining of pain on the lateral side, but the patient is complaining of pain on the after jumping. So, what are the points to be checked? So look the patella. So check again. So you have to check whether the patella, direction of the patella and the direction of the great toe. Whether the patella is directed, it is medial to the, see this angle. If you check the angle, there is a patella, there is an anterosuperior spine, and the patella, if it is bringing down, whether the patella, it is going anterior, this line, the proximal line, anterosuperior spine and the patella, if it is falling medial to the great toe, it is possible or not? So basically it is a knee valgus test, a single leg squat test, single leg standing, SLL, same name, different same test, different name. Basically, it is already known as the dynamic knee valgus test. Dynamic knee valgus test. You can see here, and you have to check the direction. See, this is the normal. This is a normal individual. See the direction of the patella. It is to almost see. Check this. See, direction of the patella is towards the great toe. Whereas check this one. This is the patient. See, it is going to be, knee is going to become valgus once the patient flexes and extended. So basically, it's a dynamic knee valgus test. What is the importance? Dynamic knee valgus is basically it's an incorrect movement pattern and is recognized as risk factors for the lower limb injuries. Otherwise, it is a result of weakness of hip abductors, hamstring, popliteus, as also there is some restricted dorsiflexion, or there are some the ankle valgus, this valgus ex equino, so that leads to abnormal knee valgus when the patient flexes or lands, there is single leg landing, that is after jumping. So that can lead to several complications, including the anterior cruciate ligament injury. That is why it is so important. So before starting the any game, the all the every athletes which the patients are complaining of any pain around any pain or discomfort around the hip, this test should be done to prevent the anterior cruciate ligament injury. Otherwise, patient can develop this. So we have to check what are the points. We have to check the line joining the anterosuperior spine and the patella, whether this line, if it is extended downwards, it is going medial to the great toe. So what are the other tests? So other test is basically it is a frontal plane projection angle and the dynamic knee valgus during the single leg and step down test. So these are the muscles. These muscles should be strengthened. So these are the muscles to be strengthened. I'm not going into detail. So this is basically knee valgus test. Now see, check this test also. Now this is a 22 years old man. It is already this question has come in the one TNB. So it is a 22 years old man complaining of the clicking sensation in his the left knee with occasional pain for last 6 weeks. So it's following a playing karate. So it's the phase of is playing karate with there is some blow should be given with the help of by blowing the foot or leg, and so this is the test is being done. Patient is standing on one limb, it's a little bit flexed, it's a little bit flexed, and there is some rotational element is added. Especially so there is some it's axial compression by the weight bearing position, there is a slight flexion, so because for the to make the balance, it is the both the limbs is supported by the examiner, and it is the patient is allowed to rotate. So axial compression, rotation, plus there is some flexion of the knee. So there is a very little flexion is given. So what is the test? Basically, it is a Thessali test of 5-degree flexion. This the same Thessali test can be done in 20-degree of knee flexion. So, okay. So basically, what are the tests? So this is a test. Patient stands flat-footed on one leg, while the examiner supports the patient by holding their outstretched hands. Patient then flexes the knee to 5 degree and rotates the femur on the tibia medially and laterally 3 times while maintaining the 5-degree flexion. The uninjured leg is tested first so that the patient may be trained with the regard to how to keep the knee in flex position. Now the same test is being repeated at 20-degree knee flexion. So what is the importance? The test is considered positive for a meniscus tear if the patient experiences medial or lateral joint line discomfort or the sense of locking or catching in the knee. Now, there are Thessaly test. This is sensitivity and specificity test of Thessaly test done at 5-degree knee flexion and 20-degree knee flexion. As the Karachiolis, you can make a study, and you can see here the sensitivity is increased when it is done at 20-degree. So in both the position, we have to check it. Now, what are the other definite tests for the meniscus? So it is a McMurray's test and the Apples test, as you can see here. And the posteromedial joint line test is the most specific test for the meniscus test. Now, see, this is another test. Check this. So, the patient is initially standing on the both the feet. Now, it is being widely apart. Now, they see there is externally rotated, and now the patient is going to become flexed, gradually flexed and extended. So standing, then making the both the foots apart, externally rotated, and now flexion and external flexion and extension. Now see, again standing, and now again it is keeping widely apart, internally rotated, and then flexion and extension. So what is the test? It is the Aegis test. Aegis test. Aegis test. It is done in the first is the knee extension. Patient stands with the knee 30 to 40 degrees and 40 centimeter apart, and depending on the meniscus, whether it is a medial or lateral, so the patient's feet are positioned to allow either the maximum external rotation of the knee, the external rotation for the medial meniscus, and the internal maximum internal rotation of the knee possible maximum internal rotation of the knee, that is for the lateral meniscus. Now gradually flex and extend the knee. So basically we are giving the axial compression, rotation, and the flexion extension. So it is a weight bearing McMurray's test, because when the patient perform this test, they have to put weight there on the knees, and depending on the meniscus we want to investigate, the patient's feet are turned maximally outwards, maximum as possible. That is during the painless limit. That is, if it is outward, foot is outwardly placed, which is for the medial meniscus. It is the inwards, it is lateral meniscus. Now, this is the test. What are the interpretation? Test is positive when there is a complaining of pain or a click is felt at the related site of the joint line. Now, further, the squatting is stopped as soon as the pain and the click is felt. Thus, the full squat is not needed in all the patients. Sometimes pain or the click may not be felt until the maximum squat. So if the patient it's tolerable, then we can allow to do the maximum squat to find the positivity. Okay. Now, this is the same patient has the MRI. The MRI can be given along with this. As you can see here, so this is the MRI, and you can see this is a vertical gap between the this is the medial meniscus, and this is a vertical gap is seen on the back, and there is some osteochondral injury, and this see the ACL, see the ACL, it is the ACL, and see this is the vertical gap in the meniscus. You can see here the vertical gap, you can check, and the ACL is normal. So basically it is a meniscal lesion. Now the question is, which type of the meniscal lesion? So it may be a root lesion, posterior root lesion, or it may be a ramp lesion. So what is it? So basically ramp lesion, it is a gap, it is the avulsion of the capsule, avulsion of the meniscus from the capsule, posterior capsule, whereas the posterior root lesion is a radial tear of the root, as you can see here. So basically the post root lesion is a very dangerous one, and if you have to identify it and you have to repair. Whereas the ramp lesion, basically, so this is the vertical gap. You can see the vertical gap on this ramp lesion. So this ramp lesion, you have to check whether the ACL is intact or not, because the ramp lesion, it is associated with it is ACL rupture, ACL, or maybe it may be associated with ACL graft failure. So after the ACL reconstruction, that can indicate there is a graft failure, and there is a high risk of developing osteoarthritis. So it is most important to diagnose whether it is a posterior root lesion or the ramp lesion. And this particular case, it is done arthroscopically. You can see here. See, this is the gap. This is this is the meniscus. It is taken. It is gap is visible from the posterior capsule, and see, this is the osteochondral component. It is see the ACL is intact. So this is excised. So this is basically is the ramp lesion. Okay, so how much time it is? Okay, it is 7:30. Okay, we can continue. So this is another case you can see here. So this is a 30 years old man presented with difficulty in walking from foot drop. Patient is complaining of maybe it may be diagnosed somewhere else by the foot drop or equinus deformity or foot drop. So with flexion of the all toes following road traffic accident. Now see, this is this is not the this is the picture of this case. This is the different picture, but see the same type of pictures can be seen on this case. So this is the equinus deformity, and can you see this is the inspectory finding on the foot, the equinus deformity, and they see this is the finding of the toes. So this is the hyperflexion of the IP joints and the hyperextension of the metatarsophalangeal joint. So this is a clawing deformity, and the clawing of all the toes, all the toes along with the equinus deformity. So basically that is there. So what is the inference? So basically it may be either the Volkmann ischemic contracture of the affecting the deeper component of the leg, or it may be due to nerve damage. Now there's a neurological injury. It may be due to the deep peroneal nerve injury. It may be due to combined superficial and deep peroneal, common peroneal nerve injury. Now, which test is being shown? So you can see here, see that the toes are being extended. Toes are being extended, keeping the ankle plantar flexed, and now it is dorsiflexed. Ankle is dorsiflexed. Now this toe extension, the passive stretching of the toes, passive dorsiflexion of the toes is being repeated. So check this again. See, so so initially the toes are being passively extended, keeping the ankle plantar flexed, whereas after that it is again it is dorsiflexed, ankle is dorsiflexed, and the same the passive toe stretching is repeated. So basically it is being tested the length of the long finger flexures, so which is commonly affected in case of Volkmann ischemic contracture. So this is the Volkmann's test. So this is the Volkmann's test for the foot and ankle. So this it suggests the fixed length phenomenon. So this is the anatomical explanation. So provisional or differential diagnosis, maybe it is a Volkmann ischemic contracture affecting the deeper components of the leg, which is involving the long flexure tendons of the toes, as also the flexor hallucis longus, maybe associated with tibialis posterior, and differential diagnosis is a nerve injury with contracture. Nerve injury with dorsiflexor paralyzed, so plantar flexors are contracted. That can be the same type of picture. So explanation is that this is the explanation. Now, how to differentiate? How to differentiate? I'm coming into this. So it's a test of VIC. Already it is test. Now, how to differentiate between the VIC and the peroneal nerve injury? Now, check the sensory loss. See if the sensory loss is the dermatomal distribution or a diffuse distribution. So if the sensory loss of the great toe with or without loss of on the dorsum, as also the lateral border, but the intact sensation on the sole. So this is basically it is a nerve territory distribution relation in the territory of the nerve. So it is either a deep peroneal nerve palsy leading to loss of great toe sensation of the first toe space and the great toe, or the complete peroneal nerve palsy. This is the whole of the dorsum of the foot. But the as the sole, it is supplied by the tibial nerve, so it is a nerve injury that indicates the nerve injury. But if it is a diffuse loss of sensation, both the dorsum and the sole, so that means all the nerves affecting all of the leg is affected. So it may be most probably it is a Volkmann ischemic contracture. So in this way you can differentiate. Now, what are the management of the VIC? You can ask by some this theoretical. So I'm obviating. Now this is now I'm going to different territory. Now again after 5 minutes we will stop and take some questions. Okay. So this is a 18 years old first bowler. It's a first bowler. So it is complaining of the loss of strength during the delivery of the ball for last 3 weeks. So identify the test. So it is a 90-degree forward flexion, some little see this abduct, it's a little bit adducted. Now it is completely pronation of the forearm, and it is the forward elevation is resisted initially by forearm pronating the forearm, and then again by supinating the forearm. See. This is 90-degree forward flexion, little bit adduction, fully pronation. Then now forward flexion it is resisted in fully pronated forearm. Now it is repeated with the supinated forearm. So what is the test? So basically it is a O'Brien's test. So what is the interpretation? Patient is asked to identify the location of the pain the patient is complaining of. So if the location of the pain is top of the shoulder, it is due to acromioclavicular arthritis. Whereas if the pain is a little bit below the clavicle, so it may be due to slap lesion. Now, if the pain is complained of during the pronated component and it is relieved by the supination component, now it is most probably it is due to the slap lesion. Okay, so it suggests this is slap lesion. So clinical anatomical basis, this particular position, that is a forward flexion adduction that compresses the labrum, anterior superior labrum, and it is propagated by the flexion, that is the long head of biceps, which is attached in the superior labrum anterior posterior and area. So this is the anatomical basis. So provisional differential diagnosis is either a slap lesion or the acromioclavicular arthritis. Now, what are the other clinical tests? So there are this is the theoretical. So this is all everything is discussed. Now, other tests are the anterior apprehension test, crank test, biceps load test, speed test, erga sense. Overall sensitivity is found to be 75 to 90%. Now, I think it will be the last. This will be the last. We can take some questions after that. A 29 years old man is a weight lifter. Now complaining of the pain and the click of his right shoulder during pushing heavy door and the bench press activity. So today we are concentrating on the young patients. Now this is a weight lifter. Now this is complaining previously it was a fast bowler that indicates a slap lesion. There is a superior labral lesion anterior posterior. Whereas this patient is complaining of again this is a shoulder pain following clicking or pain and click during the pushing heavy door on the bench press activity. So what is the test? The test is being done. See, it is 45 degree. It is abducted. As you can see here. Now it is now 45 degree abducted. Now the backward push is given, and now the left my left there is a left hand. The left hand is it is pushing downwards. Right hand of the examiner, right hand pushing posteriorly, and the left hand is pushing downwards. So again, check this. See, this is 45 degree abducted. Okay, 45-degree abducted. Now it is a downward push and the down and posterior push. Posterior and downward push is being applied. So basically it is being loaded. The posterior part as also posterior inferior part of the labrum is loaded on this position. Okay, so is there any injury like any injury during this particular movement, like during the bench press, the weight lifter, those in the weight lifter that is seen, young patients, young weight lifters, those especially during the bench press, this part of the labrum, there is a posterior and the posterior inferior part of the labrum is being compressed by the humeral head, that can lead to, by repetitive activity, that can lead to tear. So that is basically complaining of the pain, the posterior shoulder pain, and that is this is a provocative test. This test is provocates the pain on the posterior side. So this is basically it is a Kim's test. So Kim's test stabilizing the shoulder, stabilizing the scapula, whereas Kim's test is a posterior and downward push. Lesion. See the Kim's lesion, the posterior inferior capsule. This is just reverse Bankart lesion. See, Bankart's in the anterior part. This is the posterior inferior part. So basically, it is the posterior shoulder pain. This maneuver causing the posterior shoulder pain. Now, what is the problem? So Kim's test is sensitive in detecting the predominantly the inferior labrum lesion, whereas the JAF test is positive for the detecting the posterior labrum lesion. So what are the other tests? Posterior joint line tenderness, and the provocative test is a posterior apprehension test and the posterior load and shift test. Now posterior what is the here can lead to cyst formation, and that cyst can compress the suprascapular nerve, which is very easily can be, it's a big a victim of the entrapment by this cyst, and that can lead to big pain on the shoulder, and that can also causes the weakness of the rotations and the abduction. So basically, the rotation, shoulder rotation, you have to check. The infraspinatus, you have to check along with this if the patient is complaining of pain. So we have to check, we have to test by the Skims test as also the this shoulder rotations. I think I can stop and I can take some questions. Over to Janki.
Okay, Dr. Pal, thank you very much. I'm sorry I was a bit late to
Yeah, no
start.
issues, no
Yeah,
issues.
but because it
Yes,
just was traffic was crazy.
yes, yes.
So anyway, so yeah, we take any questions.
So while we are waiting for questions, sir, the current form, how many questions and for how many minutes it will be? And for one question, how much time they will get? And is it like fixed for one question, or is it variable like what we are getting in answer sheet, that we can use some questions uh, time for the another question? Is it like so, or it's different?
Yeah, basically the DNP there are basically 20 OSCE, 20 OSCE, but I have chosen the difficult one. So there are some mixture. Maybe there are 50% difficult questions, 50 maybe easier questions. So now this trend is being we can get absolute consensus of the different examiners. So you can use only the videos or those who are absolutely consensus. Now every videos are being checked by 2 3 examiners to check whether there is any ambiguity or not. So if there is ambiguity, this sort of questions becomes completely off. So it is now that is why I have shown this over test. There are several in the different way you can take it, but there is only one that is the absolutely perfect over test was done. So there is it is very easy for the examiner to for the examiner also to pick up. Now 20 questions, equal number, equal time is allotted. That is a 10 minutes. So 10 minutes is, I think it is a very good time. So first of all, we have to identify the what are the diagnosis, provisional diagnosis. So from the structured problem, and from the structured problem, there are 2 3 probable diagnosis may come in the way, and we have to then we have to come concentrate on the video, and we have to check what are the points to be noted. Suppose there is some the this Aegis test or the Salis test, as the patient is squatting, half squatting. So we have to check that there is some weight bearing is done. So there is no movement of the upper limbs and the body and the head. So basically is a test of the lower limb. So in this way you have to think. Now is the gait. We have to check from head to foot like this. So everything we have to head, shoulder, trunk, hip, knee, ankle, foot like this. So in this way we have to crack the OSCE.
Sir, so for 10 minutes for one question, so it is 3 hours and 20 minutes for OSCE.
Yes, 10 minutes, that is maybe 10 minutes for 10 questions, 10 questions. So it is 100 minutes. 10 minutes and 10 questions, 100 minutes means 3 hours. No,
100
it
minutes
is
is less
1
than
hour, 1 hour,
40
40 minutes.
minutes.
1 hour, 40 minutes, yes. 1 hour, 40 minutes.
So it's just 10 questions.
10 questions,
Sir,
yes.
okay, sir. Okay, sir. Sir, you have shown few of the test like Kim's test,
Yes,
which we do not use to read. So
yes,
is
yes.
the rare test also they can ask, sir?
So I that's the message is we have to go through all the common test. So this is not a rare test because this is the very effective test for posterior inferior labrum. Posterior labrum, it is a JAF test. But posterior inferior labrum, usually we do not use test any test. But this is that only this is a very if you go through the internet, it is a very high specificity and sensitivity. So this is the test we have to know this. Okay.
Sir, one thing like in quiz, they shows one photograph of someone and they ask, what is that? Is that any question is prepared in OSCE for that one also? Like for Thomas or some a prominent figure, they can show it and they can ask the question. Is it so or it's just subject
I
matter?
don't think so. That I don't think there's some figure. I don't think they will encourage now. Clinical, that basically the importance is given on the clinical acumen. So clinical diagnosis to pick out the hints, the abnormality, clinical abnormality like that. So I think there are some first possibility we can also discuss in the other uh, case also, other time also. So how the trend is being changed. Two videos are running by side, so we have to identify which one is that faulty. Like this sort of trend is being changed now.
So
So
it is not that you in each OSCE part there will be multiple questions.
Yeah,
And they will all have different marks. But the
absolutely.
total number of marks is how much per question?
There'll be the, I think it will be 200. So it is
So
110
it'll be
cases, so it is the
20
20.
marks per
Yeah,
questions.
equal marks. Every question has equal marks.
Just be
So there is a
bits
mixture. So,
divided
yes.
into bits.
Yeah.
so
Okay,
it's
so
not based on difficulty or
It's
like
not very
if some
difficult.
question.
So this question you have to have to pass at least 50% the total. So that will be good.
so if the DNB students don't have any questions, it means they know everything. I hope so.
Yes, yes,
Who
sir.
are
I
they?
think so because they should have doubt if something like their examination is also within a week or so, sir. Probably by I think it's
I think
24th or
that
25th,
the
something like that.
examiner should train their mind on this, how to train their eyes and to this the coincident, there is collaborate with the minds and also the thinking process to find out the diagnosis like that. So you have to they have to inspect. They have to go through this. There's a question.
Yes, sir. Why Arun has asked, case presenter case presentation will be 30 minutes for two cases. What he has told. Is
It
it
is
necessary to write the case sheet and
no, no,
submit?
no, no. No,
It's
now
not.
the merits of all cases are equal, and this is given. It is what is 30 minutes, but 15 minutes each. But every cases are considered as a short case and as equal marks. But if you ask, then the examiner can give. There is a flexible. I don't think it is so hard and fast. No
He
problem.
also asked, sir, how it's possible to examine all the points in this time, sir.
Yes,
So
that is a
usually
very
everyone has
time
that
management.
confusion.
We can discuss in again and another how to make a time management. So in that, just make a nutshell. I can give that. So don't concentrate on the history component. So we make a very smart history to take whether the disease is a traumatic disease or the infective disease or inflammatory disease like that. Suppose it's a significant trauma, so it is a traumatic disease. So pain and inability to move. It is all started with a history of trauma, so it is a traumatic like that. So if it is a trivial trauma, there may be some other causes like that. So it is a history of discharge. So don't consider, don't keep wastage of time on the elaboration of the history. Now come to the point. So suppose we are suspecting it is a traumatic disease. Now if it is a fracture or dislocation or combination like that. So in this way, so you have to concentrate on that. So concentrate also 2 minutes on history and rest of the examination. Again, you can check for the make another 5 minutes for recheck whether you are going in the right path or not. Okay.
There is last question is a bit little more important. Any shortcut, sir?
Shortcut is that is no, there is no shortcut. We have to just only one way. So I've already told we have to first is the categorization of the disease. So once it is suppose it's a neurological disease, so there's a loss of active motion but passive motion. So the wrist drop. So loss of active motion, passive motion is there. So always you have to keep your mind open. That may not be considered on the wrist, but also there is associated fractured humerus also. Suppose there is some abnormality of the wrist, but there is some associated generalized swelling. So you have to ask just whether any other abnormality are present or not. So there may multiple osteochondroma. So in this way, you have to make a shortage, I mean, very smart history. Now to very smart examination, look, feel, move, measure sequentially. No jump, no jump or jump steps. So I think that will be sufficient enough. And how to make it a diagnosis, short case and long case. Long case, everything is now equal. So we can discuss.
Okay, so
So,
thank
sir,
you very much.
yeah,
I think that was really very useful because there were a lot of things which we don't do on a daily basis, which was there. And so the students should really take heed to that and learn these tests because they need to have them at least prepared for the exam. Whether they use it or not clinically, that's a different issue, but there's some things you need to learn for the exam and they have to understand that. So thank you very much, Dr. Pal, because
Thank you. Thank you.
yeah, it's really useful getting it from you because you're involved in the exams and so that it's
yeah,
something that
even right
because
now also, sir, is in
so
one exam center.
thank you very
Right.
Thank
much
you very
and
much, sir.
until next time, bye.
Thank you, sir.
Okay.